Okay, great. So if we start with asthma. So asthma, you probably all know of someone who has asthma or even may have it yourself, but it's quite a common atopic condition, and it's associated with the atopic triad, so asthma, eczema, and allergic rhinitis or hay fever. They're the three conditions that tend to occur together, and that's because the three conditions follow the same type of pathological basis. So classic symptoms of an asthma attack are breathlessness, wheeze on exhalation. That's because you have constriction of your bronchioles and your bronchus. You also have inflammatory edema, which also occludes the airway, so causes a greater wheeze, and you have decreased lung capacity. If it's severe, you can get over time chronic changes to the lungs. So you'll get epithelial damage to the airway receptors. So they could become hypersensitive. So you may have a cough associated with chronic asthma, and you may be more susceptible to infection and inflammation. You could have increased bronchoconstriction over a long time due to smooth muscle hyperplasia, and that could mean that your wheeze gets worse and worse. If it's an acute asthma attack, a patient might present with low oxygen sats because they're really struggling to get fresh air into their lungs, cyanosis, so bluing of the skin, respiratory acidosis because of carbon dioxide retention, hyperinflation of the lungs because they're finding it quite hard to exhale. So they're getting retention of air inside the lungs, and that can then cause right heart failure. You can get type 1 or type 2 respiratory failure. And in really severe cases, you get stridor, which is a very loud, hoarse type of wheeze. And that's because of extreme airway blockage. So increased bronchoconstriction, really bad edema. And if it's really bad, your alveoli themselves could rupture, and that could cause a pneumothorax. One thing that I really struggled to understand when I was a second year is that asthma often is a chronic disease. And for the majority of patients, it's not that bad. But for some patients, because they have such bad attacks, it will be quite chronic and they'll get these chronic changes. But each attack is kind of an acute exacerbation of quite a chronic condition otherwise. So they're the symptoms. If we talk a little bit about the pathology that goes on, so it's a T helper 2 type of response. So it's associated with your cytokines IL-4, IL-5, and IL-13. So it's a bit of a revision of your immunology there. What happens is, I think I've got a photo of it on my next slide, is anything atopic means that you're sensitized to an allergen. And in this case, the allergen is usually respiratory because it's entered the lungs and it's triggered the cells of the lungs. So you get your antigen presented cells, which will present your allergen on your MHC class. I don't remember which class it was, but they present the allergen on your MHC receptors, and that triggers the activation of your T helper cells. And in particular, it triggers their differentiation into T helper 2 type cells, and these release your IL-4, IL-5, and IL-13. IL-4 triggers further T helper 2 cell differentiation, so it's like a positive feedback cycle, and you get class switching of your B cells, so you release IgE antibodies, and these then bind to mast cell receptors, which causes the mast cells to release their contents, and the granules inside mast cells contain histamine, and histamine leads to a lot of the symptoms that we actually see in asthma, and you'd probably know histamine is also related to symptoms of hay fever as well, which is why people take antihistamines, so you can understand why they're related in that way. IL-5 activates your eosinophils, and these are thought to be the major cell type involved in atopic asthma. and they release major basic protein, which causes your epithelial cell destruction, really. It damages their epithelial cell membrane, and it also induces bronchoconstriction. You've got IL-13, which activates goblet cells, and that's where you get increased mucus production. So overall, the effects of these are you get bronchoconstriction, mucus plug formation, and airway edema. The most common asthma is atopic, and this is your asthma which presents usually in childhood. It's associated with your allergic triad, your atopic triad, and it's in response to an allergen. But some people can get non-atopic asthma, and the mechanism of non-atopic asthma is not as clear. It doesn't involve eosinophils, and the onset is often later in life. So people tend to present around their 30s, and it can be made worse by exposure to cold weather, exercise, infections. So it doesn't really have an allergic association like atopic asthma does. But the mechanism of it is not as clear. Does that make sense? Then we have any questions on that? Great, okay. And that's just a diagram of your antigen-presenting cells, which presents the allergen, causes T helper 2 differentiation, and they release your IL-4, IL. I don't know why it says IL-3 there. Maybe it does also release IL-3, but that's not the one you really should remember. I think it's IL-4, IL-5, and IL-13 are the key ones, and they're the effects. Great. So clinically, the severity of asthma can be assessed in different ways. Obviously, you can tell if someone's having an attack by how severe their symptoms are, which is a very crude way, I guess, of measuring their severity. So this could be the extent of their wheeze, the extent of their breathlessness. That can give us a good idea of the extent of bronchoconstriction, the amount of edema, the amount of mucus production, to what extent their lung capacity might be decreased. But we have better clinical tests like spirometry, where we can actually physically measure the lung capacity. So does anybody know what FEV1 is, or FVC?
Would that be like forced expiratory volume in 1 second?
Great, good. So that's FEV1. And do you know what FVC is? So FVC is your forced vital capacity. So if you're imagining somebody is blowing out into the spirometer, their FEV1 is the volume of air they blow out in 1 second, and your FVC is the total volume of air they blow out in that whole breath. So, and that ratio can tell us a lot about the level of constriction of the bronchioles. Asthma is a type of obstructive lung disease, so you have a reduction in airflow. So you have both reduction in your FEV1 and your FVC, which makes sense because you've got bronchoconstriction, so less air can be exhaled. Because you have a decrease in both, either the ratio could actually be the same as for a healthy individual, or it could be decreased. And that's what makes asthma quite different to COPD, because in COPD, you tend to always have a decrease in your FEV1 to FVC ratio, and that can be a good way to discriminate between the two. Another good way to discriminate is that asthma is reversible. So if someone does have a reduced FEV1 to FVC ratio, this could be improved with salbutamol, and we'll come on to what the drugs do in a bit. Whereas COPD, that decrease is irreversible. So even if you saw a patient, you saw that they had a decreased ratio, you thought it could be asthma, you gave them salbutamol and it didn't make a difference, chances are it's not asthma, it's actually COPD, because salbutamol will provide immediate relief for an asthmatic patient. And just to note, COPD is a class of obstructive pulmonary diseases. And another big clue that's probably COPD is that it's associated with smoking, and it gets worse with age, whereas asthma is more of an allergic type reaction, which has acute exacerbations and can start in childhood. So they're the kind of differences. Does that all make sense? And let me know if I'm going too quickly as well, or too slowly. Good, okay. I assume that's all fine then. And yeah, that's a table which shows some of the key differences between asthma and COPD. I do think that's in your syllabus, which is why I put that there. And it's just good to know. So therapies for asthma. I mentioned salbutamol, and salbutamol is a beta-2 agonist. Does anybody, I know I've got it written on the slide. Actually, I'm not going to ask that question because I put it written down the slide. But so your beta-2 is GS coupled. So you get your cyclo-AMP, your protein kinase A, and you get relaxation of your smooth muscle in the airways, and that's through activation of your hyperpolarizing potassium channels. So you get hyperpolarization from the cell, you get increased uptake of calcium into the sarcoplasmic reticulum. So that means there's less calcium available in the cell for muscle contraction. And you also get activation of myosin light chain phosphatase, which then also prevents cross-bridge cycling. So you get relaxation of the smooth muscle. So overall, you get airway relaxation. You don't think you really actually need to know that level of detail for second year, because I think that's all first year stuff. But I just thought I'd revise that with you guys by having that in there. Salbutamol is short acting. So if any of you are asthmatic or have friends who are asthmatic, that's what's found inside the blue inhaler, which you would have, which you'd take a puff of during an acute attack. In your syllabus, it also says that you should be aware of the side effects of medications. So can any of you think of any side effects which could potentially be involved with salbutamol use? So one of them is written here, because you have beta-1 receptors on the heart. Salbutamol it's not a massive risk, but there's a small risk of cross-reactivity between your beta-1 and your beta-2 receptors. So you could get activation of your cardiac receptors, which could cause tachycardia. You can also get activation of skeletal beta-2 receptors, and that could cause a tremor. And also overstimulation of beta receptors could actually decrease their sensitivity and lead to internalization of them. But to be honest, I think that's very much a theoretical risk of the medication rather than actual risk of the medication. But there are other therapies which can also be used for asthma, which aren't just beta-2 agonists. And I forgot to mention, you can also give patients adrenaline if salbutamol isn't doing much, because obviously adrenaline does itself bind to beta-2 receptors as well. So in your brown inhaler, so asthmatics usually have a blue and a brown inhaler, you'll have an inhaled corticosteroid, and that it less provides relief for acute attacks, but rather it reduces symptoms and it reduces the chances of further attacks, because it's a steroid, and steroids basically suppress the immune system. So it kind of suppresses your immune system's response against any allergens which could trigger the asthma in the first place. So that's more of a long-term prevention of attacks. And then other therapies include bronchodilators. So again, if we think about your GS coupled pathway, not only can you have your beta-2 agonist, which is short acting like salbutamol, which you just spoke about, and long acting, so like formoterol and salmeterol. You can also have PDE inhibitors. So they kind of stop the inhibition of your GS signal. So you get more cyclic AMP built up in the cell, so you kind of get a more constant GS signal. So these are called xanthines, and the classic example is aminophylline, and that's given as an IV drug, and that can also cause bronchodilation. You can also get cholinergic antagonists, so like ipratropium, which is a muscarinic antagonist, and that inhibits your GQ muscle receptors. So if you remember, it's the GQ receptors on the smooth muscle cells themselves, which, when activated, cause constriction of the muscle cell. So if you get an antagonist of it, that will cause relaxation. And also your GQ receptors will inhibit mucus secretion, so it reduces the formation of your mucus plug. More recent therapies are things like your leukotriene receptor antagonists, and leukotrienes are inflammatory molecule released by your eosinophils and your T helper 2 cells involved in the asthma attack in the first place. And they can just, again, reduce the symptoms of an asthma attack. An example is montelukast. And I actually checked your syllabus, because I remember when I was learning about asthma in second year, this was very much like essay material rather than core material. But it's interesting because it is being used more and more and more, and asthma therapies are, like, the number of asthma therapies and the types are increasing. So I just thought it would be worth you guys knowing about it, because it is actually used quite a lot clinically. But I do believe it is core material to know that the leukotriene receptor antagonist is a good bronchodilator. And then if someone was having an acute asthma attack right in front of you, and the salbutamol wasn't doing much, you would, if you could, you would access option for them to breathe. You'd encourage them to sit up, you'd ask them to breathe slowly. If they couldn't take large, deep breaths. And if that was unsuccessful, you'd give them a strong steroid, which could help suppress the immune system, ipratropium, which we just talked about, xanthine, and usually they give it alongside magnesium sulfate. And again, you don't really need to know about how magnesium sulfate works, but it isn't really known. I have it somewhere in my notes, so I could. So they think that magnesium sulfate essentially acts as a calcium channel blocker. So it has bronchodilatory effects, again, by causing the relaxation of your smooth muscle and by preventing the calcium entering the smooth muscle. And then last resort, which is an emergency, would be if you intubate, and meaning that you have to intubate and ventilate a patient if they really are unable to breathe by themselves, their wheeze is getting worse, and their oxygen sat, so the saturation of oxygen in their blood is dropping. And then, as I mentioned before, there are loads of emerging therapies for asthma. So if you guys were interested in researching them, I'd look into monoclonal antibodies against IL-5 and against IgE, and there's also some against IL-4 and IL-13 as well, which are quite cool because your IL-4 and IL-13 receptors share a subunit, so one antibody can actually bind to both, which is also quite cool. And that's a new area, and I think it's probably been covered in your lectures, but the name of the anti-IL-5 antibody is mepolizumab, and the name of the anti-IgE antibody is omalizumab, if any of you are interested. Does anybody have any questions on that? I think I'm going on to anesthetics after this. Anything they want me to explain again, or explain more slowly? No? All right, great. I'll move on to anesthetics. I can't actually see the chat, so I don't know if anybody's put anything in the chat. All right, so anaesthesia. Again, some of you may have gone under general anaesthetics yourself, or have known someone who has been through a procedure which required GA. But it's important that if a patient is going through an operation, that three things happen. One is that they are unconscious, so they don't remember what's going on. Another is that they're in a state of analgesia, so they don't feel any pain. And the third is that they're paralyzed. So that means that they don't react to any painful stimuli. There's no muscle contraction or anything like that. And obviously that's important for, well, the surgeons so that they can operate. But also if a patient was paralyzed for a long operation, that could cause damage to the muscle, especially if they're lying down. And I didn't mention it, but unconsciousness entails a lack of awareness and a lack of memory, not just a lack of response. So there are two types of anesthetic drugs. There's your intravenous anesthetic drugs and your inhalation anesthetic drugs. Your IV drugs are used for induction, and the classic is propofol. And if you've ever seen it, or you will see when you go into clinicals, it literally looks like milk. It's quite thick and it's white. And they'll tell any kids who are having an operation that it's called magic milk, and it's a fun drug which will put them to sleep. And that's not a lie. It puts them to sleep. And then during the operation, an inhalation drug is used for maintenance. Why do you think it switched? Why don't we stick with an IV drug during an operation, do we think? Does anybody know?
Is it like easier to maintain a constant dose or something?
Yeah, that's one point. Especially stuff like propofol, it's got a very short half-life. So or they're saying that actually inhalation anesthetics also have a very short half-life. So that could be a factor, but I don't think that's the main point actually. Any ideas? So the main reason is because if you have a drug literally being inserted into your blood, it will diffuse into all your tissue, including your fat. And the nature of IV drugs are they're less volatile, and they're quite fat soluble. And that means that it can just take longer for them to be eliminated from the system, just because they'll stay in the fat for ages in the body. So if they're given at the beginning of the surgery, then their effects could wear off by the time the patient comes around after the surgery. But if the patient was given IV anesthetics through the whole surgery, then they can get quite a bad hangover effect, and they could be quite groggy, and that's because of all of the anesthetic which is stuck in their lipid stores essentially, and it's just taking a long time to be eliminated from the body. Whereas inhalation anesthetics, because one, they're very volatile, and two, you're literally inhaling them, so you are exhaling an amount of anesthetic with each exhalation, they're eliminated from the body a lot quicker. So they don't have so much of a hangover effect. And as you said, Matt, it means because a patient hopefully will keep breathing during the operation, you can maintain that anesthetic effect throughout the operation. I say this, but in practice, you'll see that actually a lot of anaesthetists will actually just use propofol for the whole operation. And that's because some anaesthetists love propofol, but the main reason is because propofol does have a very short half-life, and it's quite an odd intravenous drug in that way. Most of them, and I'm not sure what the other ones on your syllabus are, but the others tend to have quite a long half-life, and that's because, as I said before, they're quite lipophilic, so they'll literally like sit in your fat deposits, and it takes a bit of time for them to be eliminated. But propofol can be eliminated really quickly, so it's okay to actually give it for the whole operation. It's usually fine. And it can be quite baffling because the operation will literally have just been finished and the patient will wake up straight away because they don't need to be anaesthetized anymore. And that's good though, because they want to see straight away if the patient, if anything's gone wrong, they want to get a patient out of a state of anesthesia as quickly as possible. Analgesia, you have your opioids, which tend to be given for operation because they're stronger. So you've got your fentanyl and morphine. And I've just put there for revision that morphine is reversed for naloxone because that's quite potent. Patients are also given NSAIDs, so that could be after the operation or before prophylactically. And you would have done local anesthetics in first year, but surgeons will also tend to put a little bit of local anesthetic in the area they are operating in as well, just to have a better analgesic effect and reduce the post-operative pain in that area. And then as I said before, you often need a muscle relaxant so that the patient, one, doesn't respond to any stimuli, and two, all the muscles are relaxed, and that could be really important for an operation. So for example, if a surgeon was operating on the stomach, you would need the abdominal muscles to be relaxed so that the surgeon can cut through the abdominal muscles to get to the stomach. And if the abdominal muscles aren't relaxed for whatever reason, then that could be very hard for the surgeon. So they'll use a muscle relaxant for that. So you've got your suxamethonium, your rocuronium, which are muscle relaxants. I think suxamethonium is a depolarizing nicotinic agonist, but this was 4 years ago for me, so I don't really remember. I'm sure you can look it up, but I think you need to know what they're called and what they do. It's interesting because again, during the operations, they don't always give muscle relaxant because it's not needed for every surgery. But if there's a case where for whatever reason the patient was struggling to breathe by themselves and you needed to put an endotracheal tube in, so that's a tube that goes via their mouth down the trachea and helps with inhalation and exhalation, then you will need to give them a muscle relaxant because you would need to relax the muscles in their trachea so that you put the tube in. And then after an operation, obviously it'll be quite distressing for a patient if they woke up and they weren't able to move. It's important that you reverse the muscle relaxant, and that can be done with the acetylcholine esterase inhibitor like neostigmine. That's also a drug which is used in Alzheimer's disease. A bit of neuro overlap there, but there you go. Any questions on that? Great, okay. So other drugs, there are loads of other drugs which could be used during general anesthetics. They're not always used. It's a case-by-case basis, but if you're aware of the other drugs, it's good. So antiemetics can be given prophylactically, especially if patients have had GA before and have felt quite nauseous afterwards. Obviously, you want to optimize the quality of life of the patient. So anything that will reduce feelings of pain or nausea is preferable. So you can give dexamethasone or ondansetron, which is a 5-HT3 receptor antagonist, which are your antiemetics you can give. You can give anxiolytics, so diazepams, temazepam is the example I've written down there. Why do you think you might want to give a muscarinic antagonist? Oh, I've written it down. It raises your heart rate. So for example, if during an operation a patient was their heart rate started to reduce, they were getting bradycardic, you can give them a muscarinic antagonist to raise their heart rate. Can anybody think of potential side effects with giving a patient a muscarinic antagonist?
Low blood pressure.
Why would that be?
I just think if it's working on the M2 receptors? And if it's antagonist, maybe it's the other way around.
So your muscarinic receptors, well, so they're distributed on the epithelial cells and also the smooth muscle cells. And when your epithelial cell thinks that your M3 receptors are activated, then you get vasodilation. But if it's the epithelial cell receptors that are activated, you get vasoconstriction. So I think it probably is a side effect because you do have a lot of M3 receptors on your epithelial cells. So, but you would actually get vasoconstriction because if it's an antagonist, you would antagonize the vasodilatory effect of the muscarinic receptor activation. Does that make sense?
Yeah, it makes sense.
Good. The main side effect though of muscarinic antagonists, which is probably the most pronounced, is that people tend to have like quite dry mouth afterwards because you get reduced secretions. So you get dry mouth, dry feeling skin, dry eyes. That's a massive thing. Patients will wake up after an operation and their eyes will be really, really painful because they've been so dry. So they tend to be the main side effects of muscarinic antagonists. On the other hand, if you find that the patient's heart rate is, no, sorry, not on the other hand, the same thing. If the patient's bradycardic, you can give them a sympathomimetic, so something that also binds to your beta-1 and beta-2 receptors on the heart, causes an increase in heart rate, activation of smooth muscle cells called vasoconstriction, and also bronchodilation. If a patient is asthmatic, you can give them salbutamol during the operation to prevent any bronchoconstriction and of course it will encourage your bronchodilation. We talked about lidocaine, so for localized pain, and antibiotics can also be given prophylactically, and that's probably very important if a patient is immunocompromised, so may have HIV, may be undergoing chemo, may just have a immunodeficiency which is genetic or inherited, or if a patient's old and has increased frailty, so increased risk of being negatively affected by an infection. Does that make sense? Okay, I'll take this yes. So the theory, so this isn't really part A content, this is more part B, but it is quite interesting because people don't really know how general anesthetic works. There are a couple of theories. I think one of them is that they think the general anesthetic molecules will embed into the plasma membranes of cells and cause lateral pressure on ion channels, which then inhibits the ion channel. That's one theory. Another theory is that the molecules of the general anesthetic will bind themselves to the protein membranes, the membrane proteins inside the cell, and inhibit them, which could also be how GA works. I think the likelihood is that ion channels are inhibited and that's how GA works. It's just the mechanism by which GA inhibits the ion channels is the one which is debated. But you may have seen the graph. I think they may show you in a lecture by Overton and Mayer, where you have a correlation between the lipophilicity of the drug and the potency of the drug, which suggests that maybe it could be through the first mechanism I said, by which the drug molecules embed in the plasma membrane because they're very lipophilic, and then exert lateral pressure, which inhibits the channel. But you guys don't need to know that. That's only if maybe you want to write an essay, you can discuss that. Your minimum alveolar concentration is an important concept to know about in the case of inhalation anesthetics. So they're the ones which are used for your maintenance. and your minimal alveolar concentration is the minimum concentration of anesthetic needed in the alveoli themselves to prevent muscle movement in response to a surgical incision in 50% of patients. So it's important to know it'll be different for different patients, but this is for 50% of patients. And that will be dependent on the properties of the drug. So the absorption via the alveolar membrane, distribution of the blood, metabolism, and excretion. And it's important to know the MAC of a drug because it helps anaesthetists compare the potencies of different drugs and decide which drug will be appropriate for which patient. And then side effects of the drugs, again, you will have a lot of lectures where they go into a lot of detail about the experiments, but for the sake of your part A's, you basically need to know your inhalation drugs will depress the myocardium by acting directly on the heart, and they will cause vasodilation by acting directly on vascular smooth muscle. You can get malignant hypothermia as a very rare side effect, and that's basically if someone has a ryanodine receptor 2 mutation, which means that when they are given inhaled anesthetics, their body temperature rises to the extent which it could be fatal if not controlled adequately. IV drugs also lower the blood pressure, but they don't do that by acting directly on the vascular smooth muscle cell. They inhibit the sympathetic nervous system centrally. And that's the crucial differentiation between the two. IV drugs act centrally, whereas inhalation drugs act peripherally when they cause their side effects. And this is just going into a bit more detail about those side effects. So as I said, your inhalation agent, you depresses your myocardium by acting directly on the heart, was vasodilated by acting directly on vascular smooth muscle. Can also depress your peripheral chemoreceptor response, which can depress respiration. You get less hypoxic pulmonary vasoconstriction, which can cause mismatching of your ventilation perfusion ratio. And as I said, a malignant hypothermia is a very rare side effect. Important to note also that opiates, so morphine, also depresses ventilation. So even if you just give a patient morphine, you would see that their rate of breathing does decrease quite substantially. And then, as we said, IV drugs, they lower the blood pressure by centrally inhibiting the sympathetic nervous system. And that also causes a decrease in your respiratory rhythm generation. So you also get a decrease in breathing rate because of IV drugs. And then general side effects of anesthetics are that for whatever reason, there could be a lapse in one of those three qualities which we need. So anesthesia, analgesia, and muscle relaxant. And that could lead to some form of anesthetic awareness, which is accidental awareness during an operation. And obviously there are varying levels of severity. So it could be that during an operation, someone felt a bit of pressure, but they didn't recall it afterwards. So that would be in the minor end, but then the more severe end is that patient might wake up, which is obviously a never event during an operation. And that's pretty much it. Does anybody have any questions? I hope you guys have found it useful. If you've got any questions, please just email me or email the general organisers of this course, and they can forward the email to me as well. And if you could, I'd be really grateful if you could fill out the feedback form, and then you'll get a copy of the lecture slides as well. Yeah, does anybody have any questions, or is there anything that anybody wants me to go over again?
I don't think so. Would you mind just putting that feedback form in the chat?
Oh yeah, of course.
Is that all right?
Yeah.
Cool, thank you.
I'll do that now. Okay, I've just sent it.
Sorry if this is a really basic question, but like, why doesn't an epidural affect the whole body? It's going into like CSF.
So I don't think that's a basic question because I have to think about it. So I think epidural, I would almost in my head think of it as a local anesthetic, in that it's just been given directly to the CSF, and therefore it affects the nerve roots in that area. It must be something to do with the ADME properties of the drug. I wonder if I could do a quick Google search, let you know. Yeah, I think it's just a very localized effect, and that's because they give a localized injection in that area, whereas something like GA is given through your bloodstream or you inhale it, so it goes around your whole body. So in that way, it's kind of similar to a local anesthetic. It's just a local effect. Does that make sense?
Yeah, I just thought CSF, since it like fades the whole brain and everything, but I guess it's not in circulation maybe, so like in the same way.
Yeah, but also you need to remember that the drugs used for epidural are not the same as the drugs used for your general anesthetic. So you're probably going to use something like lidocaine for an epidural, which has local anesthetic effects. And even if that went to the brain, that wouldn't cause general anesthetic effects.
Yeah, that makes sense. Thanks.
No worries. Any other questions? Okay, well, if you have any questions, feel free to email me. I hope you guys have found that useful. And good luck for your exam. Second year is a bit of a rough year, but it gets so fun in fourth year, especially. Once you guys get to clinics, that's the best, I think. I love that. Well, best of luck. I'll end the recording and I'll end the meeting.